right? But you don't necessarily like get to see them in general. So I thought I'd show you because these come in a lot, right? Like as PCP crews, mostly in arrests and everything like that. They're pretty good in terms of what they actually do. The whole idea is like this fits any BVM, like an ET tube or something. But the whole idea is that it's kind of like an LMA in the OR or something. Like it just sits up against the epiglottis. The epiglottis sits up here, and this just sits against the larynx. So obviously this communicates directly with the trachea. And then this part, it actually is sticking down in the esophagus. So it kind of goes in and just, that's your larynx, it sort of covers like that, and then the esophagus is going underneath. It comes with a little suction tube that can be inserted down the side that'll actually goes into the esophagus just to provide a bit of just gentle suctioning for that passive goo that can come out of people. And we train PCPs to do that. They're not technically allowed to put in gastric tubes, but they can kind of put this in just to help manage some of that passive goo that usually comes from somebody just begging the shit out of somebody with a BVM, where you get a lot of gastric insufflation. So these also get better as they warm up. They tend to form a little bit. They're made to sort of mold to the larynx a bit more, so you get a decent seal, but it's not a definitive airway, right? You can still, like, if it breaks the seal at all, you'll lose your PEEP, you'll lose, you can have infiltration of stuff into the trachea. So they're good, but they're not perfect. So that's kind of how I put them. And they also, a little bit of gentle, they come with just their own super easy, like you just sort of kind of put it in, this hooks on the sides, goes under the patient's neck, hooks on, keeps a bit of downward pressure so it seats right. So they're super easy to put in. And something that is very helpful, just put your hands on it, go on, it's just kind of fun. It's a training one now, so it's just a nice, it's a really nice adjunct to have. And we'll talk a bit more about that as we finish up. No, that's my muffin, you don't care about that. And then the other thing is, I mentioned the CPAP that crews have. I don't know if you've seen them. So this is what we have that we use pre-hospitally. So it's a very simple mask setup, kind of like you might see on a normal one. It's a bit of a delicate art, putting a CPAP on somebody acutely who can't breathe. So we do, I try to, in training, like make the case of this isn't something you just slap on somebody and fire and forget, like they'll just panic and hate you. But it's just a very simple mask. This just helps adjust the headpiece up and down so it fits right, and once they're settled, you can stick the net on to hold it on their face and keep that pressure. What's neat about it is this is all there is to it, and it just goes on there. It's got a filter. It's got a red port, so you can be using MDI, so you can give Ventolin or Atrovent through there. And the nice part about it is there's a little cheat sheet on the side, but this sort of spring mechanism right here uses the flow of the oxygen to provide back pressure on the spring. So it's just dependent on what oxygen flow you set. If I set my oxygen flow at, and there's a little cheat sheet on here, at 8 liters per minute, that provides 10 centimeters of PEEP or CPAP. So it's a really just quick and easy, very simple way to provide a little bit of positive pressure for people like in a pulmonary edema or COPD that might need it. So it's actually, they work really well. I'm just kind of surprised actually, but it's very kind of the simpler the better, and it just does a good job of it if you can keep a good seal. The downside is it doesn't, because it uses the oxygen flow, you're only putting 8 liters a minute in here. So a lot of the times you might actually keep a cannula on underneath or something just to provide more oxygen, which can create a bit of a leak, but so be it. CPAP, bypass leak, so that's okay. So yeah, that's just the other thing that's available, and it's just good to know this stuff's on a car for if let's say you're moving somebody in, post STEMI or failed thrombolysis or something like that, who goes into cardiogenic, a bit of cardiogenic shock or a bit of pulmonary edema, that's a great option, right, for that. So, yeah, and something where, and we'll talk a bit more about it, the crew might not initiate that, right? That would be up to you guys. You guys mind if I shove nothing in my face while we talk? No,
Is he recording?
No, probably.
Yeah, it's recording. It's all good. I can talk.
Toby's gonna edit it.
I can cut it.
Yeah. Yeah. I think
that'd be B-roll.
Hey, how are you?
The outtakes will be be a lot funnier than the real thing.
Yeah.
So the B-roll. Hey, how you doing?
And then the green port?
The green port is Technically, you can drive a second thing off there. So, like for an inline nebulizer, so you have oxygen tubing and a nebulizer. You could nebulize, but like out of a single oxygen source is the idea. So I could run another line from the green to my nebulizer and put it in line, but you have to increase your oxygen flow by 7 liters a minute to account for that. So the downside there is you're just going to chew through your oxygen. So this is why like we would just use MDIs with this. We wouldn't bother using them now. And that's just for additional oxygenation as well that you can plug in there. Yeah. Simple device, which I thought of it. Somebody's making money. So just turning back to the human factors side, I sort of mentioned back here that there's sort of training, design, management, and culture, and I just wanted to talk a bit about those and sort of like, you know, now starting to think about what goes into moving a spicy patient, because I assume we're talking, most people's concern in a transfer isn't the one where you just put your feet up and chat with some nice old guy and go somewhere. That's easy, right? But I think people tend to worry about, you know, if things go poorly, like what can we do about that? And a lot of things go into that. So the first thing I'd say that's important, what's a human factor, something we control, was general training, right? It's your initial training in nursing school, that's where it starts. And then your experience plays a lot into it. As you get more experience, you tend to have seen more things, you get more comfortable. Maybe you just get more comfortable with being uncomfortable. It can be part of that as well. Your specialty training, like you're going into the Emerge course, you know, how long is that now, by the way? Like how long does it take to do that?
13 weeks.
Really? Yeah. So like full-time, 13 weeks, and then time with a preceptor, I assume, or something like.
Another 6 weeks.
6 weeks? Yeah, that's pretty compressed.
And then you have to do your courses before that. So like.
So you do your pre-stuff.
Yeah,
right, you just read yeah.
And then concurrently you do theory 2 and 3.
That is condensed.
Yeah, very good. Yeah, I think the first it's like the first 10 days and you're done theory 2. So.
That's a lot, eh?
Yeah.
Like, cause your brain needs time to, the problem too is like you get all this knowledge, but knowledge and application are two different things, right? Like that's what I find. Like you can read all the textbooks you want, and then you go stand in front of a sick person and you just kind of go, I'm leaving. And you just think, I don't know. So that's really important. I think informal training, kind of like this, or kind of like just talking with colleagues, I think is really actually important because it's the time where you actually get to have more of a didactic or maybe a Socratic kind of teaching where you get to bounce things around or talk about stuff that isn't just reading a textbook or looking at objectives or something boring. You know, I think it's really important to do that, get the chance to lean on experienced people and just have a bit more of a back and forth and ask questions where you might not be comfortable even in a larger setting. And then maintenance of competency, I think, is really important. What do you do over time to maintain some stuff? Because common things are common and you get very comfortable doing basic transfers, but uncommon things that you don't see all the time, those are the ones that are going to be anxiety producing, and something that, you know, if we dedicated some time to it, we can be better when those do arise. The next thing is design. Design's a big factor in human factors and how stuff goes on, right? Like even, you ever worked with a patient who's getting sicker or in a small ICU where there's not enough room in the room? You know, when you end up with like 5 people in a room and it's really built for one or something like that. How does that go? It's a shit show generally, just because you're all in one small space. And that's just a design problem. We can't fix the room, but in a larger sense, we can say, hey, no more designing hospital rooms like this. It's like one of the biggest things for paramedics is I don't know who the fuck decided how big elevators need to be, but they're too small. So, because like getting stretchers in and out of them and doing stuff, especially if somebody is unconscious, and you can't sit them up and squish them, they're on a board and need to go, it's a super pain in the butt. So like design is a huge problem. Equipment, right? You ever had problems finding a plug for something like in a room or something, or the plug's way behind, or like, you know, I know my wife in the ICU in Nanaimo, even though it's all brand new, they're kind of like, why is this like this? You know, and there's just like those little design things that just mesmerize you that somebody would do it that way. Even the new renovation in the ER here, the trauma room's still too small.
It's way too small.
Right? Like, you know, it's still not good enough. And those cause problems. Those cause people to bump into each other. It causes more stress. Just being in proximity to other people who are stressed increases your stress. And as soon as you're stressed, you're just more prone to make errors. And these little design decisions that people make have long-lasting output. And it's not that we can fix that, but at least we can be aware of that a little bit, right? And that's why like minimizing the people in the room, or like paramedics are always keen and want to learn and want to help, But at a certain point in a resuscitation, it's probably time that we get some people out of this room because we need that space, or X-ray needs to come in or whatever.
Can I add a little cert caveat?
Yeah, do it.
I do know from experience a lot of times when cert arrives at a facility, everybody's like, oh, thank gosh, they're here, right? And then everybody just kind of despairs.
Yeah, I know that feeling.
And I'm like, I don't know where anything is.
Mm-hmm.
And I'm usually running around trying to find somebody like, where's the thermometer? Where's a razor? Where's that, right? And it's so always super helpful if cert does arrive to just like stand by.
Mm-hmm.
At least for like, just getting things, it's just really nice. So
I need gauze for when I blow an IV. That's what I need.
Yeah.
It's like I just need some gauze because I didn't do this.
And I totally get it. Working rural and remote, like a lot in my own career, is like I'm just like, oh, thank goodness. The transport career's here. Whew, we're good.
Yeah. It's very true.
Yeah.
I think even systems are important, right? Like, do you have point of care testing, or does it have to go to the lab?
Yeah.
Like little things like that, where like you just want answers. Like, what's their INR? What's their lactate? Whatever you're looking at. Or does it take 20 minutes to get any good information back? So you're just guessing, which it probably does. Okay, in an IMO, you see a constant sort of frustration is blood. Mm-hmm. And having access to blood in the trauma room in an IMO has been talked about for years. Yeah. How that's still a barrier is beyond me, but I don't work there. So yeah. So these little system things are a big thing too. Even just how do you register an unknown, getting people registered, having to go through the triage process drives paramedics batty when somebody's sick, and then you're sitting there giving a triage report. It's like, we're bagging them. It's a CTAS 1. Triage done. Yeah. we don't need to talk about this anymore. Let's just go and do the things, and we can talk about like the fact that they have gout later. You know what I mean? That's not relevant right now. So, I think even just the system around the handover, which is actually a lot better in an IMO now with we do a hands-off handover. I don't know if that's trickled down to West Coast with the crews and everything like that, but I think you've probably seen it. It's pretty effective in an IMO where the crews, like we stop, we leave them on the stretcher, get a story, then everybody works to move somebody over and get it done. Because what happens before is you get a paramedic in, you're stressed, you've been working hard, you're out of breath, now you're moving the patient over, you're trying to talk, nobody's listening, people can't keep their hands off shit, so there's 800 hands going in because we got to get them on the life-saving heart monitor, and stuff like that. Like, it just all happens, and it's just natural, it's human behavior. But if you just stop and actually communicate, everybody gets to listen, and then you move them over. Because we've been with that patient for an hour, so the next 30 seconds probably isn't going to be the make or break time. And if it is, there should be a declaration of, oh yeah, they just stopped breathing and their airway's no good. Okay, well that's just time to do shit, I get that. But for the most part, you have time to do a handover that's good. And that's a system thing, that's a built-in interoperability thing that's worked out pretty well in a lot of cases.
It also throws me off because in West Coast, the nurses' scrubs are the same color as the doctor's scrubs in IMO.
That's a great, and I actually thought of that walking through, and I was going to mention that here is a good point to say, like, I really wish in Island Health, just color code people.
Standardized.
It would have a big impact on things.
Yeah.
I once stood and talked about a patient because I thought I was talking to the nurse or like maybe a resident or something in a hospital in the Lower Mainland. It was the ECG tech. Who was just like super keen and talking, and I didn't know that for 10 minutes, and I'm just like, why did I just keep talking about the 12 lead, or something? I'm like, that's weird. But that's a human factor where you can't quickly recognize who's in charge or what's going on, because a nurse here looks just like a doctor in an IMO because the scrubs are the exact same color, right? So it's a bit, which you don't worry about if you only work here, but in terms of a system thing, it can be a bit strange.
So for you might go there talking to your transfer, and you think you're talking to a nurse, and you're talking to a doctor. So like it works both ways, right?
I think even in here too, there's like everyone, like we're not consistent. Like obviously RSU's like very little, but you can't determine that versus, and then you get some docs coming in like in street clothes and some nurses wearing their own scrubs. It's like there's.
People assume that everybody knows, and that's why I sort of pointed out, it's like, take a look, at least you can sort of tell maybe the qualification of the crew that you're talking to, because if you're giving a big story about this person's ejection fraction, how they're in cardiogenic shock to an EMR, it's just like, they have no idea what you're talking about, right? So, yeah.
Okay, random question, since there's a pause order.
Just for more oxygen, if you have tubing, you can just throw some more oxygen in.
Oh, okay, just the right to the, okay.
Yeah.
Cool.
Yeah.
Didn't know.
We just don't even have basic oxygen tubing anymore, though, in our ambulances.
You don't have
It's all
extension
connected,
tubing?
no. It's all just like a cannula or a non-rebreather. Like we don't have standard face masks anymore. We either have a cannula or a non-rebreather. Because we just, it's like, nobody needs the middle oxygen. You either need a little bit of oxygen or you need all the oxygen.
Yeah.
So, yeah.
The FiO2 kind of carries over on both.
So the management side I find very interesting. And I think that really plays a lot in culture. I know it does in BCHS. I've had enough insights and meetings with Island Health to know that it's interesting here too, with how things are managed and how things work. And it's not because managers are bad people, it's just the system that we're in is different. But depending on the manager, and we have this in BCHS for sure, there's real top-down managers who are kind of coming down on the crews all the time and everything like that, and like, we need to do it this way, we need to do it this way, because that's the pressure they're getting. But then there's sort of more of a rare breed is that bottom-up manager who does a better job of insulating people from the shit and just supports people a little bit more and makes their lives a bit easier. And I think that's definitely prevalent with us, and it's probably true in around Island Health as you go and find different people working in different areas. There's also that chance to lead versus damage control, and like what's that manager? Are they actually leading, or are they just like, do they get a chance to lead? Do they get a chance to like come up with initiative? Do they get a chance to meet with people, or is it just so busy where they're just like getting shit on all the time that it's just like day to day is just damage control, damage control, damage control. Where are we floating now? We have to go into HAU, we have to go into PACU, we have to like float all these things. It's just, you never get a chance to get better because you're just dealing with mini emergencies all day. And that's kind of frustrating, but that's also a human factor because we choose to make it that way, right? If they wanted to change that, somebody somewhere could change that as a process. And then again, are they stuck in sort of this PDSA cycle, like this whole, like, you know, what you see all the time, like where, what does it stand for?
Plan, Do, Study, Act.
Plan, Do, Study, Act, right? Are you stuck doing this all the time? Like, are you doing that just to make it look like you did it in a meeting, or are you actually improving things? And I think those are two different things too, what gets said in a meeting and what actually happens. And those are decisions that get made at some level by management.
Quality improvement. Quality improvement.
Yeah, totally. But is it? Right? Some people, we do a good job of saying we're doing quality reviews, but we don't actually do anything. You know what I mean? Like the chances that something happens. And then there was a good, like I mentioned, the heat dome with IOs. There was a heat dome and a bunch of people died because the whole system, all the systems were overwhelmed, and we did all these arrests. And then what happens years later is they go, we're giving IOs to PCPs. And I'm like, there's a huge disconnect between what the actual problem was, right? Like that's not really fixing the problem. But that was at the end of all the advocacy and all the government bullshit, that's what we ended up with. And is it okay, fine, but it doesn't really fix a heat dome. It just gives people a way to drill a leg 20 minutes into an arrest that's going to die anyways for the most part. So, yeah. The last one is culture. And this is something I can't speak to as well because I'm only tangentially involved with nursing culture. And you probably have an interesting perspective having been in so many different places. I just find it's so important. Like, do you actually get your breaks? That's what I hear from my wife all the time. It's like, well, it's just too busy to get the breaks. And I'm like, did you put in for overtime? Right? And she never does, ever. Right? You know, like it is just so, but is that a culture thing? Like it's just busy, we're busy, we don't have to put in for that. It's just like, it's like, no, you need to put in for that. You need a break, right? People work 12 hours, you're gonna fuck stuff up at the end of that 12 hours. For sure you are if you didn't get a break and you're tired, right? Do you actually take sick time, or is the culture that you show up no matter what? Or do you have a good culture that's supported by a good manager that's like, no, take the time off you need, feel better, you had a horrible day yesterday, don't come here tomorrow. You need that time. That's a big thing. But what happens is there's another admit, or there's something going on, or there's something, you know, and we get stuck in this. Is that expectation there that you're going to show up and you're just going to do it? And what kind of support do you get? And that's a real culture piece. And I don't know. I think every place is probably different. In smaller teams, like within CERT, you probably have your own little support, talk, WhatsApp group, whatever's going on, right? But you know, like in the Emerge, is it the same way? Do you get support? Is there a degree of bullying? Is there sexism, which is still super prominent in a lot of cases in healthcare? You know, does all that exist? And the big one, and the reason I put it in italics, goes back to the video and something I want to talk about as we go on, is what's the hierarchy? And the hierarchy is super important because I would contend that we still have a huge patriarchal hierarchy in medicine, right? And we saw that in the video. What was it? It was a bunch of 50-year-old white guys standing around making decisions, not listening to anyone, right? And somebody died. So that's a big problem with hierarchy, and I think that's something we need to tease out in human factors. And this is where I kind of get into the teaser, or finally get to the point, is another way of putting it, is the hierarchy that you experienced in, like, who's ever encountered in your nursing career, and I'm curious, have you ever had a doctor that you're working with who's a dick? Yeah. Was that a guy? Yeah. I would say it's, yes, and I know, I mean, it's not exclusively men.
75%. Yeah.
But I think just there is more men in general, right? Because that gap still exists, and I think that it just kind of lends itself more naturally. But that hierarchy is huge, right? And if something was going wrong, how comfortable are you with saying something? Just like in that video, and that's why I find that video so poignant when he says, "Hey, the nurses did stuff of their own volition, and got a quick trach set, got a tracheostomy set, called an ICU bed, all that sort of stuff, and they completely ignored her." Right? And I think that's just so fascinating because you see that all the time, actually. You really do. And it's fun to watch traumas occur, because sometimes I just go sit in the back of the trauma room when stuff's going on, because I want to see how our crew interacts, and I like sort of watching it go down. It's fascinating to sort of see how that is. Some places are better than others. Some docs in an IO-merge are better than others, and have had
And I think that
things.
maybe add to that too is ego.
Huge.
Yeah, I think ego is the biggest thing that gets in the way, right? Just thinking about that video too, it was their ego.
Yeah.
Yeah.
But I think ego sets it up for that. But I think that we'll talk about a few other things that I think help make that actually occur as well. And the ego piece is definitely there, and it's definitely bred into some physicians because that's how they're trained. And I think that's the biggest failing, or the thing that needs to change in general, is how we have this top-down medicine approach. I don't know neurosurgery. I need a smart neurosurgeon to go and do it, but I don't need a GP necessarily, right? I need that, like you mentioned, a nurse practitioner, right? Like there's other expanding roles that come out there. The point about hierarchy that I keep not getting to is that hierarchy exists in the OR in that case, or in the ER that you guys have seen, or something like that. But when you guys go on a transfer with the crew, who's at the top of that hierarchy? You are. Because you know what the crew report will say on their PCR for that entire transfer of a super sick patient to Nanaimo or Victoria? It'll say, patient in care of RN. That's it. They are not taking any response. They're going kind of like you mentioned when the transport crew shows up. I'm out, not my problem. You're in charge. I'll help you if I can. Just let me know what you need, kind of thing. And I think that happens pretty naturally with people, more than, oh, yep, good, you know more than me, you take it over. And that hierarchy is really important, and how you come into that call is really important, because a crew, or like most people, will help you. But if you're a dick, they will probably not help you. Like it's just gonna be harder to create that. And I really support, if you get the chance, taking the time with the PCP crews that are helping you on that call to invite them into the call. They need an invitation. That most of them aren't gonna, like, it's not their world, they don't understand the trauma room, they don't understand the ICU, that's not their jam. And I think that if you invite them in, show them the chest x-ray, explain what the diagnosis is, because they don't know, like what's going on. They have a diagnosis now, or they have a CT finding. Show them the CT scan. That's a big fucking epidural. If we don't get them to Victoria for neurosurgery, they're gonna die. It's like, oh, we should go. You know what I mean? And you get a buy-in, and you get some stuff, and then you can get a chance to talk about things a bit more.
You might learn too, like a lot of them are going to school to get their ACT, or even to be a nurse, or those kinds of things. So they have a lot of
and those are resources. That's why I put 2 people at the end of the list. Is like those, like we'll kind of talk about it a bit more in a bit, but if your patient arrests on transfer, which I think is everyone's like worst case scenario, like my patient arrests on the transfer, what's your role as the transport nurse? That's something I'd ask you. What's your role as a transport nurse when you're moving somebody post TNK, felt thrombolysis, on a bit of levo because their pressure was soft, and you're taking them to the JU, and they arrest halfway down to the JU? What's your job as the nurse on that call?
Code leader? Code leader, basically, or?
Sure, so what does that look like?
Directing others to do certain tasks while you oversee the action as a whole.
Okay. Well, actually, why don't we just save this, because I got a scenario coming up where we'll maybe dig into it, because I think that's awesome. There's a lot of good discussion on that. And so here's one here. I thought I'd start with I only have 2 cases, but I thought I'd put one here just to, everyone likes talking about cases. So let's take a read of this, and then we'll dig into that a bit. Shove my muffin in my face. Obviously, I forgot in my editing.
Is this a patient that was actually here?
There we go.
That was a transfer you were supposed to go?
Move.
Like that's like literally exactly like pretty much like what it was.
Yeah?
Sorry, I was just like this is the same idea showing me right now. My trauma.
That's what I was gonna say, is this an actual patient?
No, but
Scenario?
can I, could it be? Do you guys believe, like,
Well,
that's a thing,
It's just
right?
funny because I was telling Dimitri, like when you were coming over here, I was like, last patient they wanted me to transfer was a cardiogenic shock, and I just managed to get myself out of it. Like, CERT showed up, and I was like, ah. But this was like literally the exact scenario that I was in. And I was
How
like,
long
oh,
ago was that?
how long ago? Month and a half, maybe 2 months ago.
Like August?
Yeah,
So is this
And
a,
did CERT take them?
they didn't end up going.
Yeah, that was me.
Was it? Was it?
Yeah.
Okay.
Yeah, because it was like, this is very similar.
Yeah.
Yeah.
Sorry.
okay, I just made this one up, but
Yeah.
right? So we'd agree this sounds like a real call, right?
Yeah.
Like a real potential. From what I understand of island health dosing, which is, different from everywhere else in the modernized world, 0.3 is a lot of levo, right?
Yeah.
Everywhere else, it's like, this is where we fly around the province, we're always converting things, which is another human factor. It's like, why isn't that standardized?
Yeah.
Why would we do mics per kilo per minute one and just mics per minute in another? Because you go to any other health authority, they're just gonna be on 15 or 10 or 20 levo, right?
I know when you were saying that earlier, I was like, he must do a different.
Yeah.
Because that seems like a lot, but yeah.
All,
or different, yeah.
That's a lot. All other health authorities are they don't do it per kilo for levo fed, right? So you find these different little differences all over the place. So she's on that much levo. What are the other factors in this that make this a difficult situation?
Weather.
Yeah, so let's talk about that. So so we're going from West Coast to RJH. That's a ways. That's not next door, right? So that's quite a thing.
2 mountain passes.
Yeah, so we got to go over the pass, we go over the Malahat, right? Like, it's a snowy night, right? So I think right there, there's risk in that call, right? There's risk, like there just is, snowy night, going fast. Is this person sick? So what's the impetus going to be? What's the crew going to pick up on in the trauma room from you? Like what's going to be, even if it's not spoken aloud, what's going to be the general sense of this? It's going to be urgency, right? Like we need to go. This person needs a cath lab. They need a CCU. They need to go and get all these things. So there's going to be that sense of urgency there, combined with poor weather, right? But would you think about that in the moment, or would you just be so focused on, like, well, this lady, she's like dying. They're not dying yet, but she's not doing well. So I think most of us would be clinically focused in a situation like this. But this is just why I want to put this out there to say, like, there's all this other stuff going on. What are other factors?
Potentially evolving clinical picture.
Yeah, totally, right? I mean, she's on, a buttload of levo, getting a map of 78. Okay, that's great that you have a map of 78, but you need that much levo to do it, and it's like, that's not good. So, and she's a little bit tacky. And
Oxygen levels right on the bubble.
yeah, SpO2 of 90, like that's not super comforting,
No.
right? And why? Why is the SpO2 90 is another question. So the clinical picture really plays in. Like, is that just failure? Is that just pulmonary edema? Is there something else going on? Did you aspirate? Like, who knows, right? What else? There's a lot buried in this case, actually. That's why I like it.
It's a PCP crew,
Yeah,
so it's going to be you, the advanced provider
Yeah.
in that truck.
yeah. So you've seen sort of what they have and what they don't have, and limitations, and what their understanding is, right?
You're hoping they're a good driver.
Yeah, and you don't know. Like I said, we hire people with no you don't know. This might be this dude's first day. Like,
Don't tell us that.
You don't know. But my point isn't like it could like all is bad. My point is, how do you find all of this out? Right? You need to be open to the communication. Talk to them. Hey, how you doing? What's the other big factor in this call?
You're at the end of your shift, probably.
Yeah, it's 5:30. What did you do all night? Probably dealt with shitty, overstaffed emerge shit all night. Maybe your last
Communicated this person.
patient died. 2 hours ago. You know, maybe everyone did a pediatric call this shift. Maybe, I mean, there's all this other stuff that weighs on you. You know, the break, did you get the breaks? Probably not, right? So you're tired, it's dark, we can't fly, this person's sick. There's all these pressures to go and do this stuff. While that's all there, I think what I just wanted to explore with everybody is sort of like, so those are sort of the human factors that are present, but what kind of solutions might exist? Like, what can we do to make this better? Or like think of anything like outside of the box, which everyone says too much, but like, what are other options in this case? Like, what else can we do? Because I can tell you, like, I'll start it off. Should she be intubated?
She should not be transferred at 90% on a non-rebreather mask because there is no next steps in the back of the ambulance. I cannot intubate that patient. I'm going to run out of oxygen potentially by the time I get to RGH. So the intubation maybe, but that's to have a conversation to be had with the physician.
Right, which brings us back to, hey, is that physician a dick?
Yeah.
Right? Are they open to that conversation? What's the culture in your emerge? Like all that kind of stuff.
Are they able to intubate? Are they comfortable doing that?
You know, a doctor is not a doctor is not a doctor.
Yeah.
Either, right?
Is this patient gonna crump though the moment you try to
Exactly.
intubate? Like, can they even be intubated? And then if they can't at that point, then
Yeah. So it's spicy, and the reason why cases like this are good is because there's some gray in there, right? How long does it take to intubate somebody? If you're like, okay, we should intubate them before we transfer. How long are you looking at? What's that process take by the time they're on the vent and sedated and stable and everything?
It varies. I would say a good hour.
It's an hour at least. That's sort of my number. By the time you do that, get a post-chest X-ray, like that, it probably takes an hour by the time you fart around and do all this stuff and get them sedated and lines and whatever, right? Like it can take a long, like the actual, like, okay, yeah, you can RSI them pretty quickly if RSI is the right thing to do for her. Yeah. But it's, it can take a long time, right? So that's a question. And I guess that's what I would put to you is, do you feel comfortable saying that to the team or the doc or something like that? That's something to keep in mind, because what there's going to be, like you said, there's going to be urgency and there's going to be a drive. There's a plan, and you can end up with something that's called a planned continuation error, where there's a plan and that plan is going to continue to the exclusion of any other good idea because that's the plan. The plan is to put them in an ambulance and get them to the jube, and everything else goes out the window. And it takes some realization and some recognition and some teamwork to go, hey, hold on a second. You know, like if the PCP crew walked in and you were busy and kind of didn't really think about this too much and you had that urgency, and the PCP crew walked in and went, we're not taking this person, they're super sick, you know, or something like that. Would you listen to them, or would you just dismiss them because they're not the PCP crew, they're, you know, and maybe that's right, maybe they're a brand new EMR, but are you gonna, like, it's that opening of communication, like you said, like, should those doctors in that example have listened to the nurses? Yeah, that lady probably should have been trached or criped, like, you know, they tried intubating her for 25 minutes. Are you kidding me right now? That's insane. Like, that's horrible practice, right? But they didn't listen, and that's a culture thing and everything else, and ego, like you said. The other thing I would suggest, though, is because we have this plan, my question is, what's actually the safest thing? Does she need to be at the jube? Yep, no one's arguing that. But what time is it? If we intubated her, right, and maximally supported, consult cardiology, get a bit more maybe advice or something like that, and decided to intubate, what happens now that an hour or an hour and a half goes by with some further care, another line, and intubating?
As far as like crews, if you think about crews timing out, also our CCP, like I know it's snowy.
Right.
What's happening with the weather? Are we looking at maybe in an hour or two, can we fly them in?
Maybe it's daylight. Maybe now we can fly. Maybe we have other options. Maybe day shift comes on because, like, come on, like, do we want to send this? Maybe this crew got shit kicked all night too, and now you're saying, hey, it's going to be overtime, but drive over the Malahat and everything in shitty weather. It's like, that's not.
Also think about your time frame from here to RGH. How long is that in the back of an ambulance?
Yeah.
So by the time you intubate, then the CCP crew comes and flies them out. You could be there actually sooner.
Could be. Yep. Mm-hmm. And if it's not sooner, like, time isn't the only important thing.
Yeah.
It's one of the most important things, getting them to where they need to go, for sure. But could they be Could they get another half dose of TNK? Could we look at other options? If we support their blood pressure in TNK, then might we get better effect for, who knows? Those are some doctor things, but things that could be brought up and mentioned.
Also a caveat to the individual case that we're part of is that it did not look well for this patient. So thinking about their last wishes, like I arrived and they were doing last rites at the bedside. Is it the best thing for this patient to be sent to a community completely away from her own community and family and everything, and not the outcome not be different than if she stayed here with her family at her bedside?
And I totally agree. I think just that most discussion, or has it had a chance to happen? Has the doctor broached it? Has that come up? That happened to me last year in Comox. I think we went to the ICU, and there was some GI mess lady there, and she was on pint 18 of blood, and hypotensive, and still just hemorrhaging out of the suctions, and it's oh, gotta get to Victoria. It's well, she's gonna die. We can't possibly give her this much blood on the way. We have some blood on the way, but we can't get that much. We're just tapped out. We can't even suction that much in a helicopter, or something. So
this patient had a lactate of 9.
Yeah. So
I think that's a challenging thing too, is looking at it in the sense of there's family wishes and then there's also medical, you want to respect her wishes, but also realizing
is it futile? Right? What are we doing?
Yeah.
Yeah. I think that's something that we.
Also too, so it's a snowy night. So say let's at least get them to Nanaimo, right? So, but this is what crosses my mind is the safety of the crew. So if this patient does end up going into cardiac arrest and I'm going to be doing CPR on a snowy night on the side of a road, that's putting everybody at risk, not just the patient, right? So it's risk versus benefit. So, which is, to me, is a hard conversation to have, but one that has to be had.
So that's another thing that comes up kind of to your point. Let's say, just to carry on with this hypothetical, but okay, we go and they arrest, which is a real possibility.
Absolutely.
Right? So she goes and arrests. Now, what does that cardiac arrest management look like? You guys have seen codes in the hospital, right? Are they good or bad? What's your general sense of how good a code is run in the hospital?
It really varies.
It really varies, right? It really varies. It depends on a lot of different things. My wife hates being on the code team.
Oh, really?
Hates it. Yeah.
Well, you can see that in the tower.
Yeah. But so when you show up, the question is what does this look like? So let's say that we are by Whiskey Creek and the patient arrests. Okay, everyone know where that is? Obviously, yeah. Do you know? I don't know how much you've been here, but so you're almost at Qualcomm.
With the co-op burned down.
Okay.
Kind of.
Yeah. So go up down and go past the lake, and then just past the lake there, the patient arrests. So you're about, say, 20-ish minutes, 25 minutes from here. You're about another 25 minutes-ish to NRGH, sort of halfway in Qualicum Beach, basically. And your patient arrests, declines and arrests. What do we do? You're in the back, on the monitor, on the levo, on an oxygen mask, the PCP sitting there like we just saw in the ambulance, and then other PCPs driving. How do you want to play it? Why don't you go? You haven't said much. Why don't you think? It's nice to get a fresh
Trying to be
perspective.
really quiet.
Well, there's different ways to approach it, right? And I just think it's not, I'm not here to prescribe how you do it. I'm here to encourage thinking about the options and and have you thought about it ahead of time? That's the key factor. If you're just reacting to everything, you're probably going to lose.
One of the things I was thinking before is well, this is a sketch situation, but also if the transport's gonna happen, did you talk about plan Bs and what's gonna happen if they do arrest? Planning, I'm sure everyone's planning.
Totally. You should totally have a safe word. You scream that out in the middle of a call. It's everybody knows what to do already. That's super powerful, actually, if you kind of have that plan.
And I'm not emergency trained yet or know how transports work, but I don't do you call the doctor while you're doing chest compressions? What are the steps on the transport if you're running the code in the back of an ambulance?
So good question. My impression is for ACLS stuff you don't need orders. That's a nursing scope thing.
For us at CERT would be completely different than if you were working here in your facility and doing the transport, right? Because we do have a TA. But when we have this patient and we do a bedside phone call with our TA. We discuss worst case scenarios and what our plan is if we are thinking that this person is going to cardiac arrest and what that's going to look like. So we're already going to be hopefully prepared for that. And so because there's only 2 of us in the back of the ambulance, airway compressions, it doesn't really leave a free hand to call somebody, right? And essentially we already have nurse initiated orders to perform ACLS type things. And if, like say it was like a pacing thing, we'd already have the orders for that, anticipating that kind of stuff, right? So then we would be leading it and doing the ACLS. And then if we were to hopefully be calling for ALS card and maybe come and help, and thinking about where our closest facility is and where we're gonna go, that kind of stuff. From there, calling the TA.
Not Oceanside.
Yeah, right? Well, if it's 5:30 in the morning, they're not gonna be there anyway,
Yeah.
so, yeah.
So those are all good things, right? And that's the stuff to think about is like, yes, having a plan. But my first question is like, do you pull over or keep driving?
Oh,
That's the first question,
pull over.
right? But which might not be, because most people will be like, they're sick, they've arrested, go, code 3, let's get to the hospital. It's like, that's 25 minutes away. I don't know if you've ever met anyone who's had 25 minutes of CPR, but they don't generally do good.
Especially when you're late.
Well, and that's the other
You're not
part,
doing
is
high
it's
quality
known.
CPR.
This is why most arrests are called in the field, because we discourage transport of cardiac arrest, right? We even, like, if you're shocking them, we actually just brought in new guidelines that even if you're shocking somebody continuously, we don't transport them. Now we'll do vector change, like we're training people to like change pad placement and look at other things, but like your CPR is best at home or not moving, immobile. That's the best CPR. As soon as you get in an ambulance and try to do it, your effectiveness of your compression fraction and everything goes down. Even if you think you're doing a good job, you're not.
Are they talking about bringing in Lucas to the trucks? Or?
So this has been talked about a lot. The flight crews, we have a Lucas, because if somebody's like super sick like this, I'll at least put the back plate under them when I move them over, just so that it's ready. Lucas generally probably isn't coming everywhere, because yes, it can provide good compressions, and it's great in a hospital setting, I think. But for movement, it's not awesome. It migrates very easily and comes off of like where it's supposed to be. The other thing you end up doing with a Lucas is transporting a lot of dead people.
Yeah.
Right? They're dead, but it's harder to turn off the machine because it's doing the CPR, right?
Statistically too, this patient, why can't I think of the word?
It's a stroke. This is a terrible place.
I know, right? But what are the chances? There we go. Chances was the word. Oh my gosh. that they're going to survive if we do, and if they do end up in cardiac arrest too.
Yeah, I don't know.
Right.
Not much. Some. I don't know. It's
Yeah.
tough to say, but
Right.
their best
Like, not that I
chance.
think that we should be playing God by any means,
Yeah.
right? But also thinking about that she's probably had a TNK, and you're going to put a Lucas or do compressions or, right?
It's not
Like,
coming in healthy.
Yeah. But the half-life of TNK is pretty short, right? Like, you know, like it's gone in an hour or two. So, you know, it's possible. I think that, yeah, it's interesting. And the pull-over thing, because you said like team leader, it's like, well, if you're a team of 2,
Right?
you're kind of done. The actual, and the other dirty little secret about ACLS is none of it really matters, right? Like epi, she's on 0.3 of norepi, and we're worried about giving her a milligram of epi in cardiac arrest. It's like, oh, okay, you know, sure.
Yeah.
But like CPR and defibrillating people is what saves people, right? And that's why we focus like pre-hospitally on staying good CPR, minimize hands-off time, like all this sort of stuff that becomes prevalent. So if you pull over, now you at least have more hands. The other thing I would suggest is with the eye gels, with all this sort of stuff, you know what PCPs do all the time? Cardiac arrest. This isn't new to them. The patient arrested, they'll be like, okay, they're actually pretty good at that stuff. Like they know it, and we're pretty trained in that. So you can kind of take that out of your brain a little bit, some of that actual management of it. But if you have that conversation ahead of time, they're sitting in that seat, hey, if something goes wrong and they arrest, can you have the suction ready eye gels and OPAs? Yep, no problem, right? You don't have to think about that. Don't worry about it. Would be my answer, right? Especially, you know, if they're not intubated, don't worry about it. We do this all the time with eye gels in people's houses, just because it's that time in the ambulance. They should be okay with it.
what about EMRs?
EMRs can't do eye gels.
I do that, but
So
are
the-
they pretty good, would you say, at managing airways?
In general, no.
Yeah.
which is just a factor of like training and experience, right? They just don't have as much. I think they're pretty good. This is part of a narcotic crisis is people are actually getting pretty good at just ventilating people.
Yeah.
So it's a skill that they do have. But even then, we train people to do 2-person ventilations when they don't have something in place. It's also why I like eye gels is because you can actually just have one person managing the airway, because 2 people is far superior for airway control than 1. Doing a jaw thrust with an OPA in is way better. But when you only have 3 of you, like eventually you're supposed to change CPAP every 2 minutes. Like all this kind of stuff gets pretty tricky.
Yeah, and envision that in the back of an ambulance driving to Nanaimo is trying to switch.
Yeah. Right, like
That's not
even
happening.
that, like I gotta step by you and get
Yeah.
over there and everything, like, but it's also good to coordinate, okay, we're gonna do this, that's the time we're gonna analyze. You guys use life packs, right? Like for the most part, and transport and everything, it's all life packs. We put a lot on ourselves when that stuff is going on. The life pack, if you just reach over and hit analyze, it turns into an AED. So if you're busy, just hit it. It knows whether to shock somebody or not. Like they're really good at that. So just don't feel like you need to sit there and nail this down. Now you might glance at it and go, oh shit, that's torsades. I should probably do some mag at some point or whatever. But for the most part, if you're busy and you're just trying to deal with it, and now maybe they vomit a bit and there's airway problems and everything else, there's nothing wrong with just hitting analyze. I do it because I'm by myself when I respond to calls and I have a life pack. And if I'm just super busy, I'll just stick it in AED mode. There's no shame in that. So, just go over and let it decide. And it'll time down 2 minutes for you. It's great. And this kind of brings me to just quickly talk. So this is actually something I put together for the ACPs that are starting to do transfers now that I mentioned, like because that's becoming more prevalent with all the healthcare problems. So this is like a little introductory presentation, similar like 4 hours I do with the ACPs, just to talk about that new role for them. Because there's been a bit of pushback. They just figured, you do your ALS training, you just figure you're just going to drive around fast doing hero shit all day, right? That's kind of how people like it. But this is kind of a new part of it. But the first thing we talk about actually is sort of the dispatching and where this comes in. So it's not all relevant, but there is a few things I can highlight on the right here, like the difference in just in the you guys probably don't know much about the dispatch process in general in PC. So on this side, there we go. Whoop. If you put too many words on the screen, everyone just reads the screen and nobody listens, right? Like that's the problem with Word and PowerPoint. You get a 911 call, you call 911, it's gonna go to one of the 3 regional dispatch centers in the province. So that can be in Victoria, Vancouver, or Kamloops. That's where we have dispatch centers. And it used to be geographical. So if you're on the island, it went to Victoria. If you're in the mainland, it went there, which kind of makes intuitive sense. The problem is what we ran into over the last 5 years in heat dome and COVID is you couldn't get through 911, right? Like there was this problem. So they made changes. So now all those calls bounce. So you never really know who you're talking to. It's why they'll ask you dumb questions if you call. It's like, I'm at Taylor Flats. I'll be like, where's that? Because you're talking to somebody in Kamloops, right? So they're just going to prompt you and get that, like they need to know. And you can sort of tell when you look at a call, like which area is taking that. And it's going to go there. They're going to run through something called the Medical Priority Dispatch System, or MPDS, which is a system that we bought that's basically a risk mitigation tool, but it's kind of how you ask questions in 911 and code calls. And it comes up with for instance, if you call in and say somebody's having chest pain, well, that's going to be what we call a 10 card. And that just comes from the old days. It used to be a big flip card system with 33 divisions, and you say chest pain, and you flip it to the chest pain one, and you would ask these chest pain questions, right? And so that would be the coding would be a 10 something, and then it gets subdivided into Alpha, Bravo, Charlie, Delta, Echo, with all these things being different severities based on the questioning that they come. Then what happens is all those different codings have a different level assigned to them of response. So yellow is a routine, no lights and sirens. Orange will be a lights and sirens call for a PCP crew. Some reds will be, it's a higher priority, like they will cancel an orange to go to a red, they'll cancel a red to go to a purple, is kind of how it works, which makes intuitive sense from a triage perspective. But there's a lot of argument about what is different things, because a red can be either with just a PCP crew, or a lot of reds include an ALS response, and then purples have an ALS response assigned. So the ALS ones will be like red, short of breath, chest pain, red response, ALS. Red can also just be a stroke, because those all used to be orange calls, not reds. and we finally got those changed to be red calls, because if you're having a stroke, you don't need an ALS crew, there's nothing they're gonna do, but you do need somebody quicker than an orange call. Like, you don't want to get canceled off of that call too many times if somebody's having a stroke, right? So those will go quickly. So they get coded. In essence, the calls get coded. And I can probably show you an example right here of what's going on. So, yeah, so you can see like right here, here's all these calls going on. So there's a 10 delta 2, so that's a chest pain call, chest pain, difficulty breathing. That's a red call going on in Campbell River. There's one in Coxsida, so down in like Cobble Hill area, right? There's all these different calls going on. There's an orange call right there in Ladysmith. There's a yellow call going on there in Ladysmith. So those are all the calls that are going on in coding. So they'll just move the crews and dispatch them based on that. So the calls go to the crews. When we come to the IFT side, a different process happens. So you have somebody sick in the emerge here, needs to get out. What happens is you call PTN. That's the first thing that should happen. When you call PTN, you select the level of care required. It'll ask you if you're booking a new LLTO transfer, I think, which stands for life, limb, or threatened organ, right? So super sick patient, is this a new one? Yep. You go into the queue for LLTO, your answer generally pretty quickly, you'll get an answer on that. So then what happens is the doc who is making the call here should say, yep, it's Dr. So-and-so from wherever, I need to talk to cardiology in Victoria. And I'll go, okay. And they have a list of everybody that's on call. They know how to contact everybody around the province. They also know the referral patterns that Island Health has given them. So let's say that's the referral pattern, is this goes here, from Prince George, they go here, or whatever. They have all that information there. Then they just bring on cardiology and they connect the two. What happens is they also connect in what's called the CCPA. And so 24 hours a day, there's a critical care paramedic. I do this job occasionally. There's a group of about 20 of us that work in Vancouver in the dispatch center. And you're brought in on all these red, as we call them, red or LLTO conference calls, to listen in the background and participate, communicate with the docs. Because they'll be like, yep, sounds good, yep, send them down. They go, oh, hey, hold on a second, right? because what we have, and I talked about situational awareness when you're sitting in the dispatch center, is I know what's available. I'm talking to the charge dispatcher, I know where all the planes are, I know where the helicopters are, I know the staffing levels of the critical care crews, heart, CERT, all that sort of stuff is dispatched out of the same place. So you have an eye on all of this stuff, right? And you kind of know what's going on. And you listen to it, and you get to interject and put kind of a clinical and logistical side into that. Where PTN tends to fall down is when Dr. Joe decides to call his buddy Dr. Smith down in Victoria before they call PTN. Yeah, I got a sick patient I want to send down. Yeah, sounds great. So now what happens is it slows the entire process down, and that's when everyone needs to be reconnected. And everyone's like, oh, I got to talk to PTN again. It's like, yep, you just did it the right way the first time. None of this would ever happen. So we just see it consistently. So it does tend to slow things down. But overall, there's a wealth of knowledge in PTN in terms of like where people go and connecting. And as the CCPA, you'll get it quite a bit where somebody will say, yeah, I got this femur fracture. I need to talk to ortho in Victoria. And you listen to the call. It's like, yeah, this person was ejected out of a vehicle. They came in, they got a femur fracture and they're a little bit sleepy, but they're okay. Their vital signs are fine. And then in the background, I'll be like, hold on a second. Like, let's bring on trauma from Victoria because this person needs trauma consult. They don't need ortho. Ortho's tomorrow's problem, not today's problem, right? They need the trauma, and you get to kind of have those discussions and redirect some things sometimes. So there's a big system. When I said at the beginning, a lot of people are involved. There's a lot of people there kind of managing this with eyes on that transfer to make sure it happens. And we sort of have this philosophy of going from the best possible idea. It's like, oh, hey, there happens to be a helicopter overhead with a bunch of experienced crews. They'll just land right now and take your patient. That's great. But we quickly get down to like, well, what's the next option? What's the next option? What's the next option? All the way down to, I don't know, take them off the vent and bag them and get them to Nanaimo. Maybe that's the best option at that point, to weigh everything together.
So docs are supposed to talk to other providers through
PTA, 100%. 100%. Now, if it's not that's for the red transfers. If it's a yellow transfer, like a booking, appointments, anything like that, it's a bit of a different process because it's not time critical.
Yeah.
Right. So it just happens a bit differently. This is exactly what, like when you get a call from PTN, or from PTCC, this is what we see. Like, this is what's up on our screen, and this is what the call would look like, where it'll just say, hey, you're going from Prince George to Vancouver, reason for transport LTO, working diagnosis, MVA, subdural rib fractures, hemo, and it'll have the care requirements listed, like they're ventilated, plurivac, cardiac monitoring, blah, blah, blah. And then there'll be comments, and we just sort of, this is what it looks like to the crews, or the information that gets through to CERT, and that's the information they're reading off when they talk to the dispatcher there. And then, let's see what else is relevant for you guys. So, assigning resources, yeah, well, like I said, we go from the best possible kind of down to that sort of minimally acceptable, right? Like, at some point, we're in a small town, well, what are the options? And sometimes the option is turn all that shit off, put them in a car with the EMR crew, and drive. Everyone gets all excited about things like aortic dissections or ruptures or leaking and stuff like that. And it's like, well, they get to vascular surgery or they don't. That's the only answer. So you might as well just put them in an ambulance and go for it, rather than, like, you know, taking 2 units of blood along for somebody who's going to blow their aorta. Like, what's the point? You're not going to replace that much blood. So speed is sometimes the best there. And then, yeah, so that's just, like I said, what the CCPA is available as well for all these transfers, and they just kind of have a window on things, participating, all this logistical support. And that's just what it looks like. Sit at the desk there and chat and get all the information. So yeah, it's kind of fun. I put the invite out like to a few people and Raylene and other people, and I said, hey, like, come over. If I'm working a shift, like, feel free to come over and sit in and just kind of watch the system work, because it's kind of fascinating to see when you kind of get to see it from the whole system from a different perspective. So,
You said this is in Vancouver.
yeah, this is Vancouver. Yeah, this is in the same. So this area here, so like that's a guy named Matt. We had an ITT, so it was the same for kids, doing the same sort of role, which is great. And then that's our desk, and then that sits with, like, where I'm looking at, I'm pretty much taking the picture from the charge dispatcher's desk, and there's all the people dispatching the flight crews and the airplanes, and then this is all continuous with PTN. So PTN's right there as well. So it's kind of
You're there, Brian?
Have you?
Yeah, we went a year and a half ago.
Yeah.
Yeah.
Thanks.
Yeah. So that's it. I mean, PTN, it annoys people because there's a lot of phone calls sometimes back and forth, but it's usually with a reason. And it's usually because situations change too, right? Or somebody's not available, or they get sick or something. But it really starts with trying to encourage that actual doctor-to-doctor conference in PTN. It makes a big difference.
Also, I'm sure Brian might talk about this, we'll probably will too. It's also, if you're at the facility, if that patient condition changes, to let PTN know too, so that, speaking from a CERT perspective, then it's good for us knowing.
That's something that happens too, is we have a lot of yellow transfers that don't get done in a day around the province. Like, we can't get to them, so they start calling. If we actually, around 3 o'clock, you know your planes, your resources, what's tied up, or red calls come in. They actually, in PTCC, they call it the 3 o'clock fuck you, because you start phoning all these places and saying we're not coming. So it happens pretty often with these yellow calls. But one of the jobs we do as a CCPA is start going through every yellow call and going, hey, hold on a second. Like, why is this a yellow? Like, this was booked 6 hours ago. It sounds a little sick. So then we'll phone back to Invermere or here or Tofino and go, hey, what's up with your patient there? It's like, how are they doing? It's like, yeah, they're doing a little worse. They're on BiPAP now. And it's like, they never kind of call and tell you. And it's like, oh, wait a second. Like, and then it's like, oh, that needs to be a red call. That needs to go at night, or that needs, you know, something.
Or now we need RT or.
Yeah, or whatever, right?
Yeah.
But you sort of got to have eyes on it. So that's just kind of how that works, just loosely. It's hard to describe it all because it's so nuanced, but yeah, there's a big system.